Good morning, everyone. Myself, Dr. Mohini Agarwal. Today, we are going to see history taking in pelvic organ prolapse. So, we assume a case of 62-year-old female, para 5, life 5, postmenopausal, homemaker by occupation, belongs to upper socioeconomic status, came to the OPD with complaint of something coming out of vagina since 4 years. So, this is the brief scenario of a case I had come to. In case of a prolapse, listen to the patient, what the patient says, sees, and feel about the bulge. Okay. So how you start the complaint? Chief complaint, something coming out of the vagina. Majority of the prolapse patient presents with this complaint. Okay. So HOPI patient was apparently all right 4 years back. To start with, she noticed something coming out of the vagina, which has gradually increased to the present size. Now stop. Gradually. Now, please remember you have to add this word in your history telling the gradually. Many of the majority cases, they are chronic. Okay, acute are very few. In case of malignancy, CA ovary, when there is increased abdominal pressure, then the patient may have prolapse associated, but they are very few or rare cases. So majority these are the chronic, so you have to add word gradually. Second, to the present size. Now in this, many patient does not compare the size of prolapse with like a size of a lemon or orange. But if the patient says, then you can mention so. So how you mention gradually comes to the present size. Then the patient definitely will say by the end of the day, when she has done the whole day, the work, with the increase of the work, by the end of the day, she feels the dragging sensation, heaviness in the vagina by the end of the day. Okay. And when she lies down, the prolapse goes away initially, then over a period this has not gone away. So this you start with. Now the main part, the clinch. What brought the patient to the hospital? The prolapse she is having since 4 years. Now why the patient has come now? This is the most important point. Okay, your whole viva, direction of your viva, even in for that case, for those not only PGs, for those practicing gynecologists, even what brought the patient to the hospital is the most important, so that your direction for the management treatment also depend on this. So here are the what else the complaint will be of prolapse which brought the patient to the hospital. So here are the five main complaints by which the patient will come to the hospital. And if none of these five complaints are in the presenting complaint, then still these five complaints can be a part of, will complete your whole history. Okay. So these are the very important. So we'll see one by one. First is the urinary complaint. So usually postmenopausal in exam, if it's a case, they will have stage 3 or stage 4 prolapse to you, and patient will have cystocele anterior compartment. Is the most common. Most common recurrence also occurs in this compartment after surgical correction. So very first symptom in urinary complaints is the complaint of leakage during cough, sneezing, laughing, walking, complaint of sudden urge to go to urine, not able to defer it, complain of voiding dysfunction, need to reposit the mass for urination. Usually all urinary, or for that all this complaints you have to ask a leading question. Okay, and it can be a mixed incontinence. Patient can even say complain of burning, micturition and dysuria. Because of the increased post-void residual volume, the patient may have repeated urinary infection, and that might be the prolapse patient has came to you. Okay, so one thing to remember, in a case of prolapse, when she comes to you given in the exam, if you say no urinary complaint, and in examination you're saying grade 3 cystocele, very unlikely. Okay, it's not matching the scenario. Many patients, some patients have asymptomatic, but for the exam purpose, if they're having cystocele, unless it is in a nulliparous usually there is no cystocele. So for that the different. But if you're mentioning examination grade 3 cystocele, please do mention urinary complaints in the history also. Now, unlike for the urinary complaints, bowel complaint is totally opposite. What I mean is, patient may have severe constipation or straining for defecation or need to deposit the mass for defecation. But examination may not correlate. Patient with constipation may have no rectocele or for that matter enterocele. But the patient may have no complaint of bowel, and on examination there may be grade 3 rectocele or for that matter enterocele. Okay. So bowel complaint need not be correlated. Then the third comes the bleeding or discharge. Mass is lying outside, patient it's rubbing between the thighs while walking, there may be discharge PV, there may be patient may be fearful for the bleeding PV, bleeding may be due to decubitus ulcer or trophic endometrium, whatever may be the reason. So you have to ask the detail for this. Then comes the backache. Menopausal in our society, postmenopausal in our society with stage 3, stage 4 prolapse, stretching of ligaments, go blindly and write there is backache. Okay, many patients has this, and some of them may have backache, and that's why they are presenting to you. Okay, last, not the least, not the less important, but it's important, sexual complaint. Now, very few women comes with sexual complaint as a presenting complaint with prolapse, but even if they don't, you have to include in your history. And now in this, what I want to say specifically, what I've seen with the residents is that they write no complaint of dyspareunia. Please don't write in this way. Dyspareunia in prolapse occurs at very late stage when it's not able to repulse it, or with decubitus ulcer, it has been hard, congested, lying chronically outside. Then in later stage, there is this. The first thing or initially, usually prolapse patient presents with looseness of vagina, vaginal laxity. So you sexual history, you ask vaginal laxity, loss of libido, not due to prolapse. Loss of libido may be due to of menopausal and dyspareunia in the later stage. So in sexual history, this. Now, if patient has any sexual history, you write this is present. But if there is no complaint of sexual, so how you write in your history is no sexual complaints. Okay, just don't write no complaint of dyspareunia. No sexual complaints. Now, if the examiner asks what are they, then I've already described. Okay, so these are the 5 very important completing your history. This you have to discuss. And it might be that patient may don't have any of this. The patient may come to you only with the prolapse. 4 years, she is worried something is coming out and she wants that treatment. So that may be, but you have to mention this all 5 in the negative history. So how you, again to revise a very short, urinary how complaint you will mention in the negative one is not no urinary complaint, no complaint of SUI, no complaint of urgency, no voiding difficulties, no burning micturition, no dysuria, no complaint of constipation, or no bowel complaint also you can mention, no complaint of bleeding or discharge PV, no complaint of backache if very rarely, and no sexual complaints. Okay, apart from this 5, 3 other negative history we have to take is no complaint of chronic cough, which can be due to tuberculosis, allergy, asthma, COPD, smoking, anything may be the reason. No history of any pelvic surgery, you might be dealing with the case of wall prolapse, which itself you can know in the history. Okay, and no history of trauma. Very less likely, but because of trauma to the spine, nerve injury, there are cases which leads to prolapse. So no history of trauma is also important. So this is the HUPI, the main part of the history taking in pelvic organ prolapse. Okay. So now menstrual history. Menstrual history, as in any other gynae cases, you can start with the menstrual history. There is nothing very specific about it. Ops history. Few examiners are very fond of ops history in prolapse cases, so we'll see. Now, in this case, married since 45 years, para 5, life 5. Para 1 will take a male, which is 44 years old male, home delivery. So, unlikely there is known of birth weight. Now, here you can ask for tears and any stitch, because that patient will remember, obviously, so years back, but any history of tears and likely to remember. Blood transfusion, if need to referral, if there was increased loss, and resumption of the early postpartum activity, and very less likely that she might have been advised Kegel. But these are the questions you can ask. Now, here in home delivery, you can mention or ask the patient history of fundal pressure. Okay, please here don't ask or don't mention precipitate labor or prolonged labor, because at home delivery, who is going to tell her? So please don't write the medical terms prolonged and precipitate labor in first. Now second also, suppose first was I think 44 I said, suppose second is a male again 43, conceived in lactational amenorrhea, birth weight not known. You can see the history of given fundal pressure during the labor. Then you can see when she has resumed the postpartum activity and whether she has been advised and followed the Kegels. Okay. Now para 3 will take it as female, 40 years, hospital vaginal delivery, birth weight may be known or not known. Now here you can say no history of prolonged or precipitate. You can say, you can ask the patient whether patient has been informed by doctor that it was a prolonged or a precipitate labor. Okay, so this patient might remember and might tell you. Now in hospital delivery, please don't mention fundal pressure. Now see, I've known in all hospital majority fundal pressures are given, practiced. But what I have seen is that when you mention in hospital delivery fundal pressure, the next question examiner asks is fundal pressure practiced in your hospital? Obviously, we say no, we don't give. So in home delivery, you can ask for fundal pressure. In hospital delivery, you can ask for precipitate or prolonged. Okay, so this you remember, don't confuse with this, otherwise it's all routine. Okay, after obvious history comes the personal history. Personal history: diet, mixed diet, urinary bowel complaint you have already mentioned. You can mention about the sleep, it may be less or adequate. And important here is in personal history, addiction, for that matter to be very specific, smoking, passive smoking, chula. This is again one of the favorite question of the examiner to ask. So remember that, because passive smoking increases the intra-abdominal pressure, a risk factor for prolapse. Past history specific for prolapse: tuberculosis, pulmonary tuberculosis, COPD, any allergy, asthma, cough, allergic cough, COPD, other routine epilepsy, trauma, neurologic disease. Now here also one specific thing which the examiner may ask, what else, what else, what else? That is connective tissue disorder. This is like Ehlers-Danlos and Marfan syndrome. Now postmenopausal, these are autosomal dominant. The patient themselves will say it you in the even in the beginning of the history only, but the examiner may ask, so you should just know about it. So personal is done, past is done. What left? Family history. For very specific in the prolapse for family histories, you should ask in a prolapse case history of prolapse and surgery for prolapse done in mother or the sibling sisters. Okay, because prolapse has been linked to the genetics chromosome 9. Okay, so this you can ask for regarding to prolapse. So this was the comprehensive history taking in pelvic organ prolapse. Hope you have found it useful, and if yes, please do like, share and subscribe. Thank you.